Management of hemorrhagic shock for midwives. This presentation addresses the pathophysiology and treatment of hypovolemic shock produced by hemorrhage, known as hemorrhagic shock. Hemorrhagic shock caused by significant blood loss after birth is the number one cause of maternal morbidity and mortality around the world. Let's take a closer look at what postpartum hemorrhage is and how do we define it. Postpartum hemorrhage means that there is significant blood loss that is defined as losing 500 milliliters or greater of blood after vaginal delivery. It is also defined as losing 1,000 milliliters or greater of blood after a cesarean section delivery. This is very important to know as midwives and providers because postpartum hemorrhage that is not managed successfully then leads into hypovolemic shock, which is the number one reason for maternal morbidity and death around the world. There are two types of postpartum hemorrhages that occur both within 24 hours after birth and after 24 hours. The first 24 hours of that a postpartum hemorrhage occurs within is a primary hemorrhage. It is very important for midwives to be aware of secondary or late postpartum hemorrhages, as these occur 24 hours after birth vaginally. This is important because often people are sent home from the birth center or the hospital after 12 hours of giving birth, as long as everything is normal. It is important for providers to be aware of this and also for the birthing person to be informed of what is a normal amount of blood loss and when to call for help immediately. When the postpartum hemorrhage is not able to be managed successfully and the person goes into shock, we can take a deeper look at what is shock? How is it defined? What are the different stages? And how do we identify this so we can provide knowledgeable and accurate care to help save lives? Shock is a life threatening state that needs immediate attention. It is also called circulatory shock, and it is characterized by a body wide deficiency of blood supply. It also is characterized by a body wide deficiency and decrease of fluid volume within the body. This causes oxygen deprivation to cells, buildup of waste products, and can lead to eventual organ failure. The severe hemorrhage impairs the delivery of oxygen and nutrients to the tissues, and that's what produces the state of shock. Decreases in circulating blood volume during severe hemorrhage can depress cardiac output and lower organ perfusion pressure. This is why we see an increased heart rate during shock. Because there is a depression in cardiac output, the body tries to compromise by increasing the heart rate and pushing more body fluid volume and body blood volume into the heart. The sympathetic nervous system is activated in a state of shock. This is when blood is diverted away from non critical organs and tissues and is directed towards vital organs such as the heart and the brain. There are four categories of shock. Classically, these categories are hypovolemic, cardiogenic, obstructive, and distributive shock. Today, on this presentation, we are focusing on hypovolemic, low volume shock. This is because this is the shock that comes after a postpartum hemorrhage that is not successfully managed. This is when the circulatory blood volume is severely reduced and the fluid volume within the body is severely reduced due to significant blood loss. There are four classes of hemorrhagic shock, and this is where we begin to identify shock. These are based on the amount of blood loss. In class 1, this constitutes losing approximately 750 milliliters of blood vaginally, or more. This class 1 is very important because class 1 often does not have signs and symptoms that are recognizable in the birthing person. The heart rate can be minimally elevated or it can be normal, and typically there's no change in blood pressure, pulse, or respiratory rate. This is why it's important to always monitor the amount of blood loss. Next, we go on to class 2. This is defined as 750 milliliters to 1500 milliliters of blood loss. This is when heart rate and respiratory rate do become elevated and the pulse pressure begins to narrow, but systolic blood pressure may be unchanged to slightly decreased. As we continue on, we see class 3 defines a blood loss of 1,500 milliliters to 2,000 milliliters. This then has a significant drop in blood pressure and changes in mental status occur. How this presents is a person can appear anxious, dizzy, they can begin to sweat, they can begin to look as if they're not present within the moment. These are the type of mental statuses that we need to be aware of and need to be monitoring. Heart rate and respiratory rate are significantly elevated in this stage, and urine output declines. In this stage of hemorrhagic shock, if a midwife or provider is able, it is advisable to insert a urinary catheter. That way, we can monitor urinary output and also watch for fluid volume overload due to when we administer an IV. In class 4, this constitutes a volume loss of over 40% of total blood volume. This is when tachycardia becomes more pronounced and mental status becomes increasingly altered. Urine output is minimal or absent, and capillary refill is delayed. Within these 4 classes of hemorrhagic shock, we then have 4 stages of hemorrhagic shock. It's important when a person is in shock to notice what class of shock are they in, what amount of blood have they lost, and now what stage is the body in due to the effects of shock. The 4 stages are the initial, compensatory, progressive, and refractory stages. During the initial stage, the state of hyperfusion causes hypoxia. Due to the lack of oxygen, the cells perform anaerobic respiration. Since oxygen is not abundant, the Krebs cycle is slowed, resulting in lactic acidosis. Secondly, we have the compensatory stage. This is when the body tries to compensate for the state of shock of the low fluid volume, low blood volume, and this employs neural, hormonal, biochemical mechanisms in the body's attempt to reverse the lactic acidosis. Thirdly, we have the progressive stage. This is when all of those compensatory mechanisms begin to fail. As fluid is lost, blood concentration and viscosity increase, causing blockage of microcirculation. This prolonged vasoconstriction will also cause the vital organs to be compromised due to reduced perfusion. As we remember, the vital organs also constitute the heart and the brain. If the bowels become sufficiently ischemic, bacteria may enter the bloodstream, resulting in additional complication of endotoxic shock. Lastly, we have the refractory stage. This is the final stage in which the vital organs have failed and shock can no longer be reversed. This is the tragic stage where brain damage and cell death are occurring and death is imminent. Shock is irreversible at this point as a large amount of cellular ATP has been degraded. This is the tragic outcome of maternal death and morbidity. It is when the postpartum hemorrhage leads into hypovolemic shock, and those stages of shock are not able to be managed. And then a person gets into the 4th stage, the refractory stage of shock, which leads to death. Hemorrhagic shock can be rapidly fatal. This is why it is of utmost importance to estimate blood loss, monitor vital signs, monitor any possible classes and stages of shock a person may be entering into or are presently in. The primary goal is to stop the bleeding. Resuscitation is dependent on estimated severity of hemorrhage and the management of the shock. Whether or not one fully resuscitates a bleeding person depends on the rate of bleeding, the ability to control the bleeding, and the presence of coagulopathy. The first step in managing hemorrhagic shock is recognition. As we mentioned in the previous slides, in class 1 hemorrhagic shock, we may not have any signs from the person, quite possibly a minimally elevated heart rate, though we do know this person has lost 750 milliliters of blood, therefore they are in class 1 hemorrhagic shock. This is automatically when IVs need to be administered and emergency services need to be called. Many of these symptoms present simultaneously, but they may not show right away. These symptoms that define shock can be seen in the person as when a blood pressure drops significantly, body temperature plummets into a fever, there's blue lips or fingernails, the person has an altered mental state such as anxiety or confusion, dizziness, excessive sweating from the body temperature, loss of consciousness, low or no urine production, a rapid heart rate, shallow breathing, and a weak pulse. Management for the treatment of hemorrhagic shock. The first step in treating hemorrhagic shock is to call emergency services 911. Stop the bleeding by applying fundal pressure while administering antihemorrhagic medications. Administer oxygen 40 to 60% via a medium concentration mask at a flow rate of 4 to 10. Maintain oxygen saturation above 90% ideally. Start an IV in the antecubital vein with a 20 gauge catheter. It's important to always do this, if possible, with a 20 gauge catheter because when a person is in a state of shock and they are either in the hospital or sent to the hospital, blood products can only be transfused through a 20 gauge catheter. Administer normal saline solution or a crystalloid solution rapidly at a 3-to-1 ratio. Position the person in shock to be supine with the legs elevated at 45 degrees. Consider a Foley catheter to collect and monitor urinary output. Watch carefully and closely for fluid volume overload by listening for crackling or fluid in the lungs, difficulty breathing in the person, or edema in the legs. When the person is in a somewhat stable state, it is important to run labs of HTB, HCT, CBC, bune, and creatinine and lactate levels to see how their liver is functioning. There are team strategies for improving outcomes of hemorrhagic shock. Most importantly, when there is a shock emergency, it is important for the birth team to communicate out loud as a team before any action carried out to the client. This ensures that everyone is on the same page and no one is administering too much of an antihemorrhagic medication, and everyone is able to speak out loud what they are doing. This enables the person charting to be able to chart accurately and in a timely manner, especially for emergency transport. Do not delay calling emergency services. It is best to ensure a birth team has IV skills and knowledge of administration of antihemorrhagic medications. It's really helpful during this time if one person can help to apply fundal pressure while another is administering antihemorrhagic medications. At the same time, it's great if there's enough people on the team to have one person administering oxygen and another person establishing a successful IV and beginning to administer fluids. This is all very important to note and continuously refine as midwives to know how to recognize the signs of hemorrhagic shock, how to recognize and classify each class and stage, and how to manage this life threatening outcome in the commitment to reducing maternal and infant mortality.